Welcome to our video on normal labor and delivery, part 1. Let's get started. In this lecture, we'll be discussing rupture of membranes, fetal lie presentation and position, as well as fetal heart rate monitoring. Let's begin with rupture of membranes. First, let's talk about some different terms associated with rupture of membranes. Spontaneous rupture of membranes, also known as SROM, is rupture of the chorion and amnion after the onset of labor. Spontaneous rupture of membranes is a normal process. However, changes in its timing and duration may predispose both the mother and the fetus to peripartum infections. Premature rupture of membranes, or PROM, occurs before the onset of labor. Another related term is PPROM, that is, preterm premature rupture of membranes. PPROM is just premature rupture of membranes at less than 37 weeks of gestation. Finally, AROM stands for artificial rupture of membranes, which is performed if the amnion does not rupture on its own after the onset of labor. Bloody show indicates the blood-tinged vaginal mucus that is related to the onset of cervical effacement. We talk about these conditions in great detail in the lecture called Complications of Labor and Delivery. All right, let's move on to fetal lie presentation and position. Fetal lie is the relationship of the fetal longitudinal axis to the maternal longitudinal axis. Fetal lie can be longitudinal, oblique, or transverse. Longitudinal lie indicates that the fetal and maternal vertebral axis are parallel to each other. Oblique lie suggests that the angle between the fetal and maternal axis is less than 90 degrees. Finally, a transverse lie means that the angle between the fetal and maternal axis is 90 degrees. Let's discuss the fetal presentation as well. Presentation is determined by the body part of the fetus that is deepest in the maternal pelvis. The most common type of presentation is cephalic, which means that the baby's head is the presenting part. In contrast, breech presentation indicates that the fetal rump is the presenting part. There are some rare types of presentations, like that of brow and face. Here's an image of the longitudinal, oblique, and transverse fetal lies. The longitudinal lie means that the fetal and maternal vertebral axis parallels each other. It's further divided into the cephalic and breech presentation. In the cephalic presentation, the fetus is presented head first, whereas in the breech presentation, the fetus is presented with feet first. On the other hand, oblique lie suggests that the angle between the fetal and maternal vertebral axis is less than 90 degrees. Finally, transverse lie suggests that the angle between these two axes is 90 degrees. Here we see the different types of breech presentation. We have frank, complete, incomplete, single footling, and a double footling breech. Frank breech is characterized by flexed hips and extended knees. In contrast, the fetus in an incomplete breech presentation has flexed hips, one extended knee, and one flexed knee. Complete breech is characterized by bilaterally flexed hips and knees. Single footling breech means that one foot of the fetus is out of the cervix, while double footling breech means that both feet are out of the cervix. Now let's talk about fetal position. Fetal position is the position of the fetal presenting part relative to the maternal pelvis. Please keep in mind that occiput anterior is a physiologic position associated with the least complications. Cephalic presentation is characterized by multiple different positions depending on where the fetal occiput is directed. We have occiput anterior with left occiput anterior and right occiput anterior positions. At the same time, we may have occiput posterior with left occiput posterior and right occiput posterior positions. Lastly, the fetal head may assume the left occiput transverse or the right occiput transverse positions. Let's show this with an illustration. Here we can see the different positions of cephalic presentations. In the straight occiput posterior position, the fetal occiput is directed towards the maternal coccyx. The left occiput transverse position is characterized by the fetal occiput directed towards the left ilium of the maternal pelvis. In the left occiput anterior position, the fetal occiput is directed to the left anterior part of the maternal pelvis. In the left occiput posterior position, the fetal occiput is directed to the left posterior part of the maternal pelvis. The straight occiput anterior position is characterized by the fetal occiput directed towards the maternal symphysis pubis. The right occiput transverse position is characterized by the fetal occiput directed towards the right ilium of the maternal pelvis. In the right occiput anterior position, the fetal occiput is directed to the right anterior part of the maternal pelvis, and in the right occiput posterior position, the fetal occiput is directed to the right posterior part of the maternal pelvis. All right, let's try a question. A 32-year-old G2P1 woman is brought to the physician by her husband reporting severe lower abdominal pain. She is feeling regular, strong uterine contractions. A Leopold maneuver is performed, which reveals that the fetal head is located near the maternal symphysis pubis, and the angle between the fetal and maternal longitudinal axis is from 0 to 90 degrees. The labor progresses, and the physician observes that the fetal occiput is directed towards the maternal symphysis pubis. What are the fetal lie, presentation, and position in this pregnancy? All right, this question is focused on determining the fetal lie, presentation, and position. Since the fetal head is located near the maternal symphysis pubis, the presentation is cephalic. The fact that the angle between the fetal and maternal longitudinal axis is from 0 to 90 degrees suggests that the fetus is in an oblique lie. Finally, the fetal occiput is directed towards the maternal symphysis pubis, indicating that the presenting part of the fetus has an occiput anterior position. Therefore, the fetal lie, presentation, and position in this pregnancy are oblique, cephalic, and occiput anterior, respectively. All right, now let's move on to discuss fetal heart rate monitoring. The normal fetal heart rate is anywhere from 110 to 160 beats per minute. Therefore, fetal bradycardia is when the fetal heart rate is less than 110 beats per minute, while fetal tachycardia is a fetal rate greater than 160 beats per minute. The normal fetal heart rate variability is anywhere from 6 to 25 beats per minute. This is an image from our partnership with Amboss, which highlights several important features of a normal cardiotocograph, or CTG. The top part of the image shows us the fetal heart rate. Notice that the baseline fetal heart rate is between 100 and 160 beats per minute. This image shows how we perform the electronic fetal heart rate monitoring. Here you can see a pregnant woman with 2 transducers on her abdomen. The upper transducer is called the external fetal heart rate monitor because it records the fetal heart rate. The lower transducer is called the uterine tachometer because it measures uterine pressure. Here we have the fetal monitor showing the actual changes in heart rate and uterine pressure. The fetal monitor produces graph paper, which gives us valuable information about the conditions of the fetus. Here's an image from our partnership with Amboss, which highlights several important features of normal cardiotocography, or CTG. The upper part of the CTG indicates fetal heart rate, while the lower part shows uterine pressure. The x-axis for both components displays time. Each small box is consistent with 10 seconds. Since each big box consists of 6 small boxes, the big box is consistent with 60 seconds, or 1 minute. The y-axis for the fetal heart rate monitor shows the actual fetal heart rate, while the y-axis for the uterine pressure graph shows the amplitude of the uterine pressure. The fetal heart rate is measured in beats per minute, and the uterine pressure is measured in millimeters of mercury. Notice that the fetal heart rate in this case varies between 120 and 150 beats per minute, which is normal. The normal range for the fetal heart rate is anywhere from 110 to 160 beats per minute. Also in this example, the maximal heart rate is approximately 150 beats per minute, while the minimal heart rate is somewhere around 123 beats per minute. Therefore, the fetal heart rate variability is the difference between these two numbers, which is 17 beats per minute. And a normal range for fetal heart rate variability is between 6 to 25 beats per minute. Now that you have a basic understanding of CTG, let's dive into the clinical relevance of these in a bit more detail. An important concept to be familiar with is an acceleration and a deceleration. An acceleration is defined as a sudden rise in the baseline fetal heart rate of greater than 15 beats per minute for greater than 15 seconds. And a deceleration is exactly the opposite. A sudden drop in the baseline fetal heart rate of greater than 15 beats per minute for greater than 15 seconds. There are 3 types of decelerations: early, late, and variable. They're distinguished from each other by the timing relative to uterine contractions. In order to remember the etiology of decelerations, we can use the mnemonic veal-chop. A variable deceleration is caused by umbilical cord compression, while an early deceleration is due to fetal head compression. An acceleration is okay because it's a normal finding on fetal heart rate monitoring. And finally, a late deceleration, which is the most ominous type of decelerations, is due to placental insufficiency. Knowing how to differentiate the different types of decelerations is important as it can affect the management. So let's discuss them one by one. As I just mentioned on the previous slide, variable decelerations occur due to umbilical cord compression. This is usually caused by oligohydramnios. Recall that the amniotic sac, when sufficiently hydrated, provides a cushioning for the umbilical cord. Therefore, oligohydramnios, which refers to amniotic fluid volume that is less than expected for gestational age, is the major cause of umbilical cord compression. All right, let's discuss the pathophysiology behind late decelerations in more detail using this image. Recall that veins contain less smooth muscle and collagen than arteries, so pressure on the umbilical cord initially occludes the umbilical vein. This results in decreased fetal blood flow, and eventually an increase in fetal heart rate due to sympathetic nervous system activation. Then the umbilical arteries are occluded, and this causes increased afterload. High afterload exerts increased pressure on the fetal carotid baroreceptors, which in turn will increase the vagal tone. Increased vagal tone will then decrease the fetal heart rate. Finally, pressure relief off the cord results in normalization of the fetal heart rate. Here we can see a CTG image showing variable decelerations. This is the initial acceleration phase, which corresponds to umbilical vein compression. The initial acceleration phase is followed by abrupt deceleration, which corresponds to compression of the umbilical arteries. Finally, we see the return of the fetal heart rate back to the baseline, which corresponds to pressure relief off of the umbilical cord. Variable decelerations have no temporal relationship to uterine contractions. Additionally, they're abrupt because the onset to nadir time is less than 30 seconds. Intermittent variable decelerations are the ones present with less than 50% of uterine contractions in 10 minutes. In contrast, recurrent variable decelerations are present with greater than or equal to 50% of uterine contractions. Observation is usually sufficient for intermittent variable decelerations. However, for recurrent variable decelerations that do not respond to conservative measures like maternal repositioning and amnio infusion, emergent C-section may be needed. Let's move on to early decelerations. These are usually caused by fetal head compression due to uterine contractions. Let's discuss the pathophysiology on the next slide with the help of an image. Uterine contractions can result in fetal head compression, and this raises the intracranial pressure of the fetus, which in turn increases the vagal tone. Increased vagal tone decreases the fetal heart rate. This is a CT image showing early decelerations. As the uterine contraction starts, the increased intracranial pressure in the fetus results in vagal overactivity and a decline in the fetal heart rate. When the uterine pressure reaches its peak, this is when the fetal heart rate deceleration reaches its nadir. Finally, once the uterine pressure returns to the baseline, vagal overactivity stops and the fetal heart rate returns to the baseline as well. The early deceleration is synchronous with the uterine contraction. In other words, the nadir of early deceleration coincides with the peak of uterine contraction. Additionally, the onset to nadir time of an early deceleration is greater than 30 seconds, and an early deceleration is a benign finding of the fetal heart rate monitoring. Therefore, no intervention is needed. Late decelerations are usually caused by uteroplacental insufficiency. This is usually secondary to conditions that compromise placental blood flow and proper delivery of oxygen and nutrients to the fetus. For example, diabetes, hypertension, and cocaine are among the most common risk factors. Uteroplacental insufficiency basically means insufficient placental blood flow. Decreased placental blood flow decreases the fetal blood flow through the umbilical vein, which in turn results in fetal hypoxia and acidosis. Decreased partial pressure of oxygen stimulates the chemoreceptors, and the fetus's chemoreceptors in turn induce diffuse fetal vasoconstriction, resulting in increased fetal blood pressure. Increased blood pressure stimulates the fetal baroreceptors, which in turn increases vagal tone. And finally, increased vagal tone lowers the fetal heart rate. Here is a CTG image showing late decelerations. As you can see, the late deceleration starts right after the peak of the uterine contraction. This is because the placental blood flow decreases to its minimum at the peak of uterine contraction due to increased external pressure on the uterine vessels. Increased vagal tone caused by the baroreceptor response to fetal hypertension gradually decreases the fetal heart rate. Once the uterine pressure returns to its baseline, placental blood flow increases again, resulting in normal fetal oxygen delivery. This will stop the activation of chemoreceptors and baroreceptors, making the fetal heart rate return to the baseline. All right, let's review the key points about decelerations. A late deceleration starts after the peak of uterine contraction. Its onset to nadir time is greater than 30 seconds, just like that of early deceleration. A late deceleration is an ominous finding, and it needs maternal and fetal evaluation. Intermittent late decelerations are the ones that are present with less than 50% of uterine contractions, while recurrent late decelerations are present with greater than or equal to 50% of contractions. Management of late decelerations should begin with IV fluids, maternal repositioning, and stopping uterotonics. As I mentioned previously, if uteroplacental insufficiency is present, increased uterine contractions can further compromise the delivery of oxygen-rich blood to the fetus. So uterotonics could be one of the factors exacerbating and or even inducing late decelerations. Oftentimes, with recurrent late decelerations, conservative measures aren't enough and emergent C-section becomes necessary. Now let's discuss the sinusoidal fetal heart rate pattern. This is characterized by sine waves with regular amplitude and frequency. Absent beat-to-beat variability is also noticeable. In other words, the fetal heart rate lacks the normal variability of 6 to 25 beats per minute. It's also associated with fetal anemia. Although the exact mechanism is unknown, fetal anemia is thought to cause the autonomic nervous system dysfunction, as well as increased serum vasopressin levels, which induce the sinusoidal heart rate pattern. This is a CTG image showing a normal fetal heart rate. The black sinusoidal line above reveals the typical appearance of sine waves with regular amplitude and frequency. All right, let's finish off this section by talking about fetal heart rate categories. Category 1 fetal heart rate is the normal tracing. Category 2 fetal heart rate is any type of tracing that does not meet the criteria for either Category 1 or 3 tracings. And finally, Category 3 fetal heart rate is characterized by recurrent late or variable decelerations, fetal bradycardia, or a sinusoidal pattern. Fetal 1 heart rate tracing needs just observation and expectant management, as this tracing once again is normal. Category 2 is first managed by maternal repositioning, IV fluids, and oxygen. Refractory cases may require expedited delivery. And finally, Category 3 usually needs urgent delivery in addition to all of the conservative measures, such as repositioning, IV fluids, and oxygen. All right, let's wrap up with a final question. A 34-year-old G3P2 woman comes to the physician at 36 weeks of gestation for a routine prenatal visit. She has a past medical history of type 1 diabetes mellitus diagnosed 20 years ago. She is on a daily insulin regimen. Her previous 2 pregnancies were complicated by fetal macrosomia. Cardiotocography at this prenatal visit reveals a gradual decline in fetal heart rate with an onset to nadir time of greater than 30 seconds that starts after the peak of uterine contraction. What is the most likely cause of the cardiotocographic findings in this patient? All right, this pregnant patient with a 20-year history of type 1 diabetes mellitus has CTG findings classic for late decelerations. Specifically, there is a gradual decline in fetal heart rate with an onset to nadir time of greater than 30 seconds that starts after the peak of uterine contraction. As I discussed on a previous slide, late decelerations are due to uteroplacental insufficiency or inadequate placental blood flow. The most likely cause of uteroplacental insufficiency in this patient is diabetes-induced hyaline arteriosclerosis of the placental vessels. And that concludes this section.